Well, good evening, everybody. I'm glad you all could join us tonight. This is Linda Wyman Collins. Most of you know me as Lou. That's my initials. I've been involved with HFA since 2000 as on board of directors, on the professional and medical advisory council, on different committees. Right now I'm co-chairing Blood Sisterhood. So I'm glad you guys are all here. You've probably seen articles on and off that I've produced in Dateline or seen me at symposium because I've spoke, or I'm always, if you, nothing else, you've seen me as the infusion suite nurse at symposiums. I this year was excited because I got a National Nursing Award from the Cherokee, actually Scrub Company, and they have a nonprofit called Inspired Comfort. And I was their grand prize winner, which I was more excited about because it's given me the opportunity to publish and raise more awareness of women's bleeding disorders. So there's been articles in nursing magazines or even just on the website that I talk about it. And I also got Dallas-Fort Worth's Great 100 Nurses. So I also, again, got to publish and put out some more information on awareness of women's bleeding disorders. So I was excited about that. Just want to give you a couple of housekeeping tips before we get started. That said, you know, this webinar tool, it's a great thing because you get a chance to learn while you're still in the comfort of your own home. We want you to participate in this whole webinar. So if you are in the VoIP or the voice mode where you're using your computer and your microphone and speakers, you want to double check and make sure using the audio checklist that your microphone and speakers are working okay. If you are in the phone mode, make sure that you look over there on the right and put in the PIN number because you'll need to put that PIN number in so when there's a chance when you can talk that we can hear you. If you're just called in, just the listening only mode, just with your phone, you'll be able to hear all of the webinar, but you won't be able to ask any questions. So while the speakers are talking, everybody's going to be muted. But when we open up the microphones for discussion, if you aren't speaking at that point or asking a question, if you could please keep your phone muted so that we don't get a lot of background noise. And then, you know, just unmute it, or there's a little thing in your little right-hand side screen. There's a thing where you can hit and raise your hand that you have a question, or there's a little box down at the bottom, a little chat box, where you can type in a question. And I'll be looking at that ever so often to see if there's a question that I can bring up to the speaker. And tonight's webinar is probably going to last about an hour. Dr. Sidonio is going to talk for about 45 minutes, and then we're going to open up to questions for about an hour. Now, Dr. Sidonio, he's completed his pediatric hematology oncology fellowship at the University of Pittsburgh under the mentorship of Dr. Ragney in 2010. Well, under Dr. Ragney's mentorship, he developed an interest in women with bleeding disorders and has started a women's bleeding disorder clinic with an adolescent provider to address an unmet need of managing menstrual bleeding in women with a bleeding disorder. While in his fellowship, Dr. Sidonio completed the Clinical Research Training Institute sponsored by the American Society of Hematology. He was recruited to Vanderbilt University in 2010, and in 2011 was awarded a KL2 as a Vanderbilt Clinical and Translation Research Scholar and a Catherine Dodd Faculty Scholar. These awards have currently funded his ongoing study in female hemophilia carriers. And I had met initially just online talking with Dr. Sidonio when he was getting ready to start this study on carriers. And then I've got a chance to meet him in person at a couple of symposiums and to hear him speak at our last HFA symposium. So I'm really excited that he's on tonight, so I'd like to turn it over to him now to give his presentation. But thanks for joining us.
Well, thank you, Lou. I hope everybody can hear me well, and thank you for joining me tonight. So I'm going to go through this fairly quickly, and there are two parts to the presentation. One of them will focus on a case-based presentation regarding the management of women with bleeding disorders. And I tried to keep it broad because I wasn't sure exactly of what type of bleeding disorder population the audience was going to be. And in the second portion, I'll have some preliminary data from my hemophilia carrier study and some preliminary data from the CDC. So all of this is prelim, and it may change in the final analysis, but I thought since HFA helped me initially with the survey, that would provide you guys with the data that we have at this point. So these are my bad habits here, conflicts of interest. So we'll start off with a case. So this is a common scenario that I see in my clinic. A 13-year-old female presents with heavy menstrual bleeding. Oops. And she reports that her periods last about 8 days. She has to change her pad every hour or two. She has a little bit of prolonged skin bleeding, some nosebleeds. Usually that's seasonal, and she's been anemic at times, requiring iron pills. And this information is typically not obtained unless you specifically ask it. And so this is something that I found that a lot of people don't know to ask these specific questions. And so one of the things that I think a teenage girl struggles with is, what is a normal period? And so a typical period, at least what I've been told, lasts about 2 to 7 days. Most of them last less than 5 days, and it usually is on cycles about every 30 days. When you talk about heavy menstrual bleeding, a simple definition would be anything lasting more than 7 days on a regular sort of period. And then the very clinical definition that we use is over 80 milliliters of blood per cycle. And since nobody knows exactly what that means, thankfully we have things that help you, when you ask the right questions, will predict whether you actually have heavy periods. So if a woman reports to a physician that she passes clots that are greater than 1 inch, she's had iron deficiency anemia for no other reason, and then she's changed her pad or tampon every hour at times, or has had what we call flooding, or multiple times have had accidents, then that's usually fairly predictive of actually having heavy menstrual bleeding. So it makes it a little bit easier to ask and less of a very specific, how much blood have you lost over the last month. And so one of the things that I've learned over the last year or two was that women with bleeding disorders are more likely to report the following. One of them being dysmenorrhea, or having more pain. This is something that I've noticed because it's not something I feel like I can do a lot about, being a hematologist. And because of this is one of the reasons we're starting a women's bleeding disorder with a gynecologist, so I'm bringing somebody in that can help deal with the dysmenorrhea. There seems to be more reporting of mid-cycle pain, seems to be a higher frequency of polyps, fibroids, and endometriosis. Some of this may be related to the therapies that we have to use. One thing that people sort of underestimate is the effect of heavy menstrual bleeding on a teenage girl particularly. It's been shown to lead to poor quality of life and poor self-esteem. That makes sense. I think everybody in the audience would probably agree that that limits the amount of sports activities and things that you do. We have to write notes often to allow girls to leave during class if they need to, because schools are so strict about these things these days. So when you look at sort of prevalence of bleeding disorders, this is sort of based on multiple articles, but these are the disorders that we should be looking at as physicians when a woman comes to me or adolescent girl says that she has heavy menstrual bleeding. So this is the minimum that we do to look for things. So it's important to know that von Willebrand disease is as high as 13%. Platelet dysfunction, depending on, I've seen things as high as 40%. I'm not so sure about that. It's probably closer to 10 to 20%. And then looking for things like factor 11 deficiency, which is hemophilia C. It's sort of the forgotten hemophilia. And so these are the things that we look for when girls present with heavy periods. I really like this chart from Dr. Andy James, and I'll focus, I have some arrows on here, and so it's really based on, it's a very question-based algorithm. Would you like to preserve fertility? If the answer is yes, then we sort of use medications like DDAVP, antifibrinolytic medicines, being Lystida, which is tranexamic acid, which was recently FDA approved for use in women with bleeding disorders. So we use it pretty frequently, particularly where I'm located, where a lot of mothers are hesitant on putting their daughters on birth control. And then Amicar can be used, but Lystida is a much better option and has been approved and studied in at least in adult women, and it soon will be studied by Dr. Sarah O'Brien in Ohio State. If you look to the right side of the algorithm, if you are not interested in preserving fertility, so these are usually older women that are done having children or not interested in having children at the time, you can do more hormonal measures. And these are things like progestins, combined birth control, various things like patches and rings. IUDs have really sort of emerged and come into use. It does take a significant amount of skill because there's a lot of bleeding that happens with initial placement of the IUD, and you can have cervical bleeding early on that needs to be addressed. So some women may need to be treated prior to placement of the IUD. And then the final options are obviously endometrial ablation, endometrial artery embolization, and hysterectomy, which should be the very last option and should be reserved for older women that have completed their reproductive cycle. So when you look at definitive therapy options, these are, I just put a nice chart together to say how we would definitively treat things. If factor wasn't an issue, if we didn't have to give it through IV, obviously we would reach for that a lot quicker. But it's a little bit more difficult when most people with von Willebrand disease rarely ever get IV therapy. And so if you look in the left column, the plasma and recombinant concentrates are indicated for these disorders. FFP, unfortunately, is the only thing we have available for factor V deficiency. Platelets can work as well. And then at this time in the United States, plasma is the only thing we can use for factor XI deficiency. That may change over the next year or so. We do have prothrombin concentrates that have factors 2, 9, 10 in it that we can use for that purpose. And then people with rare bleeding disorders like Bernard-Soulier or Glanzmann's may have to require platelet transfusions and very rarely recombinant factor VII. So one of the things that we're trying to work on, and I know Dr. Dietrich in Baylor has a nice setup for this where they're trying to better track how much menstrual bleeding is going on. And this is an example of something, it's on victoryforwomen.com, menstrual diary. And so the darkness sort of corresponds with how much blood is in there. So when we start therapies, we like for women to follow these and utilize these. And we're trying to work to make this electronic because these little paper diaries are, personally, I don't think they're as helpful because I've never had a woman be able to return them. It's usually, if we can make it electronic, I think it would be a lot easier. And I think that should be a goal of some of the organizations to make this an app. And this is the same thing similarly when you use tampons. And so moving on to the second case, so now you have the teenage girl with heavy periods, and now you have the 30-year-old who has a bleeding disorder, and I left it generic, who's considering pregnancy. She wants to discuss prenatal counseling, and her bleeding history that elicited is that she had nosebleeds as a child, but now that she's older, they've gone away. She really hasn't had a lot of, she has not had dental procedures, and so hasn't been challenged in that mode. And she has heavy menstrual bleeding. She had tried birth control in the past. DDAVP and Lystina helped a little bit, and finally an IUD was something that sort of helped, prevent pregnancy, but also reduce menstrual bleeding. So when it comes to prenatal counseling, these are one of the things that should include multiple providers, a genetic counselor, an OBGYN, and a hematologist. And I think this is where the push to sort of get women's bleeding disorder clinics off the ground, and that would feature close collaboration of these providers, because traditionally a gynecologist is not involved in the comprehensive care. And I can tell you when I've reviewed the data, currently almost 30% of people being seen at a hemophilia treatment center are women. And in the next decade, that's actually going to be above 50%. So I think we're going to have to sort of think about most women get their primary care from gynecologists, so I think gynecologists are really going to have to be a part of the comprehensive model. And then there's multiple different ways of doing prenatal testing. There is a way to detect the fetal sex determination. It's really not widely available in the United States, but you can determine if you're having a boy prior to ultrasounds. We haven't really found a really good role for that, but it's something if somebody wants to know very early, you can find out prior to ultrasound. And then invasive testing is something that we should be at least discussed. It doesn't have to be performed, but it should be discussed. And if you look on the left side, we get a piece of the chorionic villi for analysis. This can be done a little bit earlier than amniocentesis. The miscarriage rate is extremely low. It's less than 1%. And done in the right hands, it's probably even lower than that, probably less than 0.1%. But that's an option that should at least be discussed. It doesn't need to be utilized by every woman. That's a personal decision, obviously. One of the things that I've learned over the time is that this is a discussion that we should be had with women, and 13% of all women in the United States have miscarriages. It's likely higher with these following disorders, and that's von Willebrand disease and the following factor deficiencies. This has not been rigorously evaluated. These are usually self-reports, and so that tends to overestimate the miscarriage rate, and so we need better studies on this. I have some data from my study. I haven't analyzed it yet, but I went back and added this question based on my discussions with women who brought this up. I think this is a nice chart. I'm not going to go through all this detail, but I know this is available for everybody. But if you look here in the red, during pregnancy, your factors can go in 3 different directions, either stay the same, go up, or go down. Von Willebrand factor, factor 7, 8, 1, and factor 10 tend to increase during pregnancy. So this is a nice thing for hemophilia A carriers and patients with mild von Willebrand disease, that typically the factor 8 and von Willebrand factor go up 2 to 3-fold by the 3rd trimester. So it's important to know that, but not every patient has that. We have multiple women that it doesn't budge. And so this needs to be verified, particularly prior to epidurals. If you look in the middle, unfortunately these are the factors that really don't change much during pregnancy. And so there is an issue with patients with factor 9 deficiency or hemophilia B carriers where it statistically does not increase. And so those women are at increased risk for postpartum hemorrhage because the natural protective mechanism is for women's factor 8 level to be sky high and protect women. And then when you have a low factor 9, that can put you at risk for bleeding, particularly if it doesn't go above 50 to 60%. And then finally, people with factor 13 deficiency, it actually goes down, unfortunately. And platelets tend to drop during pregnancy. It's something called gestational thrombocytopenia, and it's something to be aware of. So if you have a platelet disorder or type 2B von Willebrand disease, it may exacerbate that and make it a little bit more challenging. So now moving on to that case, we've talked about prenatal counseling. She wants to discuss the following: an epidural anesthesia and a delivery plan. And one of the issues that I've noticed is this discussion happens way too late. It happens usually at the time of somebody about to deliver, and that's not a discussion you want to have about whether you can get an epidural or not. And so these things should be discussed prior to this, and it's really important. I think in general we've been very lax with this, particularly with hemophilia carriers. And so I think it's really important that we check levels during pregnancy, and we'll talk a little bit more about that. But prior to any invasive testing, we need to make sure that your factor level is above the hemostatic level. One of the things some women are not aware of is that 50% is not the magic number for every factor. Some factors you don't need that much to approach what we call hemostatic level. That is the level typically needed in factor 8 and 9 deficiency or carrier state, but everything is different. And one of the things I think, prior to me reviewing the guidelines, I don't think our institution or other institutions were verifying this, but for C-sections, you need to be above the hemostatic level for almost a week, and for vaginal deliveries for at least 3 to 5 days, because once you've had the baby, your levels are going to start plummeting at that point, and that puts you at risk for postpartum hemorrhage within the first 2 weeks. And since most women aren't followed immediately within the first 2 weeks following pregnancy, that could put them at undue risk, and it puts unnecessary stress on the woman who just had a child and has excessive menstrual bleeding. That's the last thing that she wants to deal with. So this is a chart. I know it's very busy, but I'm putting it together for a review article that I'm writing with Dr. Kulkarni, and this is a sort of a summary of all the guidelines. As you can see, that if you start from the left side, that's the United Kingdom guidelines. The next one is the World Federation of Hemophilia. The next one is the Australian guidelines, then the Canadian guidelines, and finally MASAC and /NHF. And most of them say the same thing. There's a little bit of controversy on the preferred mode of delivery, particularly for hemophilia carriers. So that's a little controversial. MASAC is the only one that's really come out and said C-sections is recommended. And I think that's a push from Dr. Andy James, who feels very passionate about this. But the data doesn't really suggest that that's the preferred mode. But it's something at least to discuss, so between you and the provider. So the other thing is that this is the chart I thought would be helpful. I'm not going to go through all of it, but it gives you sort of what's considered the minimal level needed to clot. And so that is different. So you can see for factor V deficiency, you don't need a lot to clot. And thankfully, the half-life of some of these factors are quite long, particularly when you're looking at things like factor 13 deficiency, which people that have this disorder often only get factor concentrates once a month, unless they have issues. But it just tells you that often if you need to get treatment, hopefully it's only one time, particularly if you have to be exposed to a plasma-derived product. And so now that same 30-year-old female is delivering via vaginal delivery. She calls you and says that she's having really heavy periods. She's changing her pads every 1 to 2 hours. You remember that that's a sign of heavy periods from this talk. And so one thing that we don't discuss enough and unfortunately happens all too often is postpartum hemorrhage. And so the definition is greater than 1/2 liter of menstrual blood loss in the first 24 hours. And secondary postpartum hemorrhage is when you lose more than that after 24 hours. So it happens in the general population, but it happens more often in women with bleeding disorders. And so the ways that you can avoid it are active management of labor, avoid forceps. The word forcep and vacuum extraction should not be in any discussion with anybody that's probably on this call. And you should always know what your third trimester factor levels are, because that's going to give you a good idea what it is. And if you're, for example, if your factor 8 level was very low and it only rose to 50–60%, then you could be at significant risk for postpartum hemorrhage. And at least we can plan to have a plan in place in case you do have trouble or you run into issues. And that could be with something, could be with stimate or intranasal DDAVP. I think it's good to follow up with either the hematologist or the OBGYN within the first 2 weeks. And then it's good to have a post-pregnancy contraception plan. That we do that in general, but I think with women with bleeding disorders, they really have to take charge of this and really come up with a plan prior to this. It's not something you want to have to discuss sort of at the last minute. And so, so this 30-year-old had an uneventful delivery, and now she's asking about optimal timing of testing and circumcision. This scenario comes up all too often in the middle of the night, or when it's been 9 months and the mother has told the OBGYN and told the anesthesiologist, told everybody that I'm a carrier, and everyone sort of blew it off until the last minute until the baby's born, and then I get the phone call. So I think this is something we should discuss ahead of time, and it should be in a plan, and that's something I think we want to work on here. So the optimal test timing and testing. This one's a little bit tough, and so if the circumcision, it really depends on when the latest date of the circumcision can be done without anesthesia. Every place is a little bit different, but usually after 1 or 2 weeks, it becomes a general anesthesia procedure and requires urology or surgery, and they typically defer until the baby's at least 10 pounds or sometimes even more for safety with anesthesia. So if there's a severe bleeding disorder and the ones listed here, then it definitely makes sense you should test early. And I think, to be honest, testing for von Willebrand disease makes sense as well, even when it's mild von Willebrand disease. And this illustrated by this slide, that the von Willebrand factor and factor VIII are very elevated in the first 4 to 6 months, and you can see the vitamin K dependent factors and the ones listed here are not quite as high later on. One thing I've learned over time is that when you say hemophilia carrier, most physicians have absolutely no idea what that means. They assume that it's probably factor VIII, and I have had too many instances that I've heard about where the physician assumed it was factor VIII, checked the level, it was normal, and it wasn't conveyed that there's a family history of factor IX deficiency, and the child went on to have significant bleeding from the circumcision. And unfortunately has had 2 instances recently I've noted had required blood. And so we have to be very specific in our language saying factor VIII deficiency and factor IX deficiency. And so one of the things that comes up a lot in neonatal ICU is what do you do for the the neonate that may or may not have a bleeding disorder. And so for female infants that when we're talking about hemophilia carriers, we're not as concerned because the levels tend to be high. But for either sex, for the other disorders or males with hemophilia, potentially with hemophilia, We typically like to avoid the vaccine, the hepatitis B vaccine, because there's no urgency to give it. I actually tell mothers to tell them to put a sign over the crib saying no heel sticks, because it can be all over the chart, but if it's not over that crib, it's going to get done. You're going to get a heel stick, and there have been too many children have to require factor 2 to 3 days later, not typically at the time. You know, if it's planned ahead, you can actually do cord blood testing, and the baby doesn't even have to be stuck. We always delay circumcision until test results are known, and I personally recommend giving the IM vitamin K and holding pressure for 5 minutes. I have not seen any issues with this. We follow every patient that has this, and I discuss it with the mothers. Vitamin K deficiency by itself will cause significant bleeding, and if you have a child with a potential bleeding disorder, that is not a good combination to have. I've seen plenty of children get intracranial hemorrhages 1 to 2 months later because they didn't get their vitamin K shot. That shot costs $1. And so it's one of those things that I think it's definitely meant to be done in this, particularly in this high-risk group. And we don't typically give special instructions for mild von Willebrand disease or mild platelet disorders with regards, because most of the mild procedures are not going to cause problems. But with circumcision, you know, we can test for von Willebrand disease early, knowing that we'll have to test again later, but at least it allows the circumcision to be done. And so this is a summary of what we, you know, when it comes to hemophilia carriers, because that's my sort of area of interest. You know, these things should be discussed. It's still a little controversial, as you can see here, about DDAVP, that there is always the concern for causing a drop in sodium in the baby. But Italian studies and Dr. James and many other experts have not seen this. It hasn't been demonstrated. And so most people would say that it can be used with caution. One of the things that we talk about, timing of testing, if you review the literature, there's been no data to suggest that testing a child or testing an adolescent girl has long-term negative effects. And it doesn't seem to be, in my study and in previous studies, that women don't seem to change their family planning. I think this question would be very different in the age of HIV and contaminated blood products, but I think this day and age, I don't think that's really so. And so personally, I think people should be tested as early as possible, whether they have hemophilia, whether they're a carrier, or whether they have hemophilia. So my push would be to do this, and that's where I've been trying to drive the community to do. So the main thing is that you should always advocate for yourself. If you're not comfortable with something, if you talk to the hematologist, most of the gynecologists would be more than happy to discuss it with them. I've had many conversations, and I think this is where we can get together as patient advocacy organizations and physicians, and I personally think we should be developing handouts with the personalized plan, but make it a little bit sort of cookie cutter, but I think we can add areas where we can personalize it. I think, you know, that should be in the hand of every, you know, woman with a bleeding disorder, and they should hand it over to their OBGYN and anesthesiologist, because one of the issues is, you know, I can put a plan in the mother's chart, but when the baby is born, the physician is not going to be looking at the mother's chart. They're going to be looking at the baby's chart that has nothing in it. So I think that's important to hand that over to the physician, and still, since we do use paper. You know, we really think, I personally think there should be at least a request or consideration for high-risk care. It makes me very nervous, and I just saw a child recently, a hemophilia carrier, she mentioned it multiple times, and unfortunately still got a vacuum extraction, had to get 3 doses of factor and required phototherapy in the hospital because of jaundice. That is a totally preventable thing, and so I think I worry about private practice not knowing about this, and I think that's where some of these organizations can do outreach. And then I think, you know, I think people could be advocating for women's bleeding disorder clinics. A lot of the hemophilia treatment centers don't have the 340B programs where they have the money to set these things up. We don't personally have it, but we're trying to put our resources in this, because I personally feel very passionate that a women's bleeding disorder clinic is relevant, and I think women are going to be the future of hemophilia treatment centers, because there are a lot more women with bleeding disorders than there are males with hemophilia, and that number is going to continue to rise, and I think most women will find that they get better care when they come to the hemophilia treatment center. So these are some nice websites that most of you guys are probably aware of. And right now I'd like to go into the hemophilia carrier study results. And I'll go through this fairly quickly because I know that the most important thing is probably what the results are. And so this is sort of the roadmap that we like to use when we approach a clinical research problem. So it starts with an observation. We do a retrospective study, or maybe we do a chart review. Then we actually spend the large amount of money it takes and effort to put together a prospective study. And then we sort of want to look at why does this happen. Like, for example, for hemophilia carriers, why do hemophilia carriers bleed more even when their factor levels are normal? So there has to be some reason, and that's where the scientists would need to investigate. And the final step would be actually to prove that therapies work in carriers. And so this is how I approached one of the problems. And I've changed a little bit of the information of the patient that I initially met. But this was a 26-year-old female who was an obligate carrier. Father had hemophilia. She was 7 months pregnant. She was coming for a pregnancy plan. Her factor levels have ranged anywhere between 40 to 70%, which is pretty common. And she had her first factor activity checked at age 25. Unfortunately, that is extremely common, and I think that's something that I would like to change in the next 5 to 10 years. When you asked the bleeding history, you know, she reported the things that I would expect to see, maybe some mouth bleeding, some heavy periods, but she discussed having joint bleeds. And so as a physician, that wasn't something that was really taught to us, and because of that, I went back to the literature to see, well, does this actually happen a lot, or is this just an isolated incident, particularly in a woman that has fairly normal factor levels? And so there was some data on this. The first description was in 1952. 19 women, about half of them said that they had reported oozing from dental extraction. That's the first evidence, but there's really only been about 5 articles total describing bleeding in hemophilia carriers. The best one was done in 2006, and most of these articles, unfortunately, have been performed in Europe, where they have, you know, socialized medicine, so they can actually have access to all the records. In this study, the average factor activity level is about 60%, and you can see the range was anywhere between 5 to 219%, which is a nice bell-shaped curve. And when you looked at, you know, the thing that was interesting to me is the women that had low levels, I expect them to bleed. I think anybody expects them to bleed. But I think what was most interesting is when the levels were over 40%, which most physicians would say should not have significant bleeding, 8% of the women reported joint bleeding. And then 20% said they bled after tonsillectomy, and 39% said they had prolonged skin bleeding. So, you know, this is a little bit different than what we expect, particularly when you make the cutoff of the definition of hemophilia at 40 or 50%, depending on which definitions you use. And so this is sort of what launched my sort of research. And so we actually started off when I was at a regional meeting, and someone from HFA was there, I think it was Kimberly, and we had talked about this. And so, so based on her discussion with me, we decided that we would take a survey, give it to HFA as the cases, and then also give it to providers. And so you can see here, my hypothesis is that hemophilia A carriers report excessive bleeding symptoms that is under-recognized by providers. So it was one of those hypotheses that I knew was probably going to be true, because I knew most providers that had talked to me said that you're wasting your time on this because hemophilia carriers don't have significant bleeding, and so you're not going to find anything. And so we sent out surveys, and as you can see here in the top, this is the breakdown of the providers. And so we were able to get almost half the people respond. These were seasoned people. These are people with over 20 years experience. Most of them were females, and most of them worked in hemophilia treatment centers. When you look at the characteristics of the carriers, which were the people in HFA, the average age was about 34. The baseline activity reported was 48, and this was reported, so I couldn't verify if this was true, and the range was similar to previous studies. And as you can see here, most of them were mothers or relatives, at least, of males with severe hemophilia. Most of the people did not receive regular care as expected. And so the key findings were, when you ask a simple question, do you think that carriers with normal activity have increased bleeding tendency? So a simple majority of providers thought so, compared to 78% of the carriers. So that was statistically significant. And then one of the things that I wondered is why are we not testing these carriers earlier? 72% of the providers wanted to defer testing after age 14, compared to 22% of carriers. So there's obviously some discrepancy here, And this is sort of, so we've sent this out, and hopefully this will be published in the next couple of months. And I'd be happy to provide a free copy for the Blood Sisterhood, since HFA was critical in getting the survey. So based on this information, we went ahead and started a prospective study. And what we wanted to do, and I'll go through this quickly because I know I want to go to the actual results because I know that's what people are wondering on. I wanted to see whether women had significant joint asymmetry, meaning one joint is reduced in range of motion compared to the others, and whether their mutation had anything to do with it. For example, did a mother of a child with severe hemophilia more likely to have joint bleeding versus a mother of a child with mild hemophilia? So that's not the end that anybody's really looked into, and we wanted to verify with MRIs. That was sort of the most expensive portion of this. And so as we're talking right now, we have 2 radiologists here that are reviewing it, and I can tell you preliminarily that 2 of the MRIs showed evidence of old bleeding in the joints. And so I think that's going to be really a big deal, and that's what it's going to take to convince older physicians particularly that this is a real thing. And so we made the cases that are mothers of hemophiliacs, and we actually also have an arm where we're looking at sisters. And in our control group were mothers of children with cancer because we needed some sort of control group. So here is the interim analysis as of 2 days ago. And so if I draw your attention to the top, the first column are the cases at Vanderbilt that were recruited. So these are hemophilia A carriers. And then if you look in the middle column, these are the controls, or these are the mothers of children with cancer. So these are not women that have any bleeding disorders because we tested them. And then up to the right, at the HFA meeting last year, actually, not this year, I was able to recruit 19 women for the survey because I wanted to get additional people for the study. So I was very grateful for HFA for that. And so one of the things that we looked at, one of the first questions that we looked at were, have you ever had a bleeding event? So it's shaded there. So if you look at the cases, 53% said yes. The controls, less of them did, of course. And then more so at the conference, which is not surprising because probably it's more likely that when women go to these conferences, they're more likely to have symptoms that would motivate you to go to a conference. And so that's not surprising. So that's the danger of doing surveys at conferences. When you ask what's the age of your first bleeding event, and so that average age was 12 years of age. And you can see the confidence interval was anywhere between 8.5 and 24. And so, one of the things that I wanted to prove was that because the notion that women that are carriers don't bleed in childhood, then you shouldn't test them. So I wanted to flip that and say, well, most of the women said that they had their first bleeding event in childhood. And as you can see here, the site, this was actually very surprising to me, that 3 of the women had reported that they had joint bleeds. And this is only the first bleeding event. This is not total. So there was a total of 7 women that had it. And so oral bleeding was the first on 19%. There was some muscular bleeding, nosebleeds. I was surprised that intra-abdominal bleeding was common. And then heavy periods, which I thought was going to be the most common, was there as well. If you look in the controls, heavy periods, that's a common bleeding symptom in women, so I wasn't surprised that 2 women had that problem. And then if you look at the cases, heavy periods was the most common bleeding symptom. But again, joint bleeds was on the radar, which again was surprising to me. So this chart is sort of helps you look at just when we were talking about bleeding symptoms. So I just discussed the first bleeding symptoms. These are the bleeding symptoms that you've ever had. If you look at the cases, skin bleeding seems to be the most common, which is expected. If the factor VIII level is a little bit low, you're more likely to have prolonged skin bleeding. When you look at the next most common, when you look at cases and ones recruited from HFA, it's sort of split between joint bleeding and postpartum hemorrhage. And so I was actually a little bit surprised by that because I really didn't think joint bleeding would be that commonly seen. Nearly 40% of the cases reported ever in their lifetime, and almost 20% of the cases in our study have reported it. So that was actually quite shocking to me. And these are obviously much higher than you see in the controls. So you see some skin bleeding, that's a common bleeding symptom. But the surgical bleeding, you do see that because surgical bleeding happens in 5% of people. And postpartum hemorrhage, that happens unfortunately when the uterine, wall doesn't contract appropriately, and heavy periods. This just tells you that why you need a control group, because heavy periods are a common problem in women. But you can see here it's a lot more common in women here, and we defined it as more than 7 days. A lot of women don't define it that way. They just sort of deal with it. They think 8 days is normal. That is not normal. That's heavy. And so one of the things that we wanted to look at is interim analysis. So these are the cases at our university and HFA. When you look at it, it's very striking that 90% of women think, and 100% here, think that we should be testing girls before they're adults. I think that's completely true. I would agree with this category, testing prior to age 14, and if a girl needs to have a procedure, she should be tested before that. When you ask the women, were you tested to see what your activity was, this is kind of shocking that 53% of the women were not tested. I think that's really a shame that women were not tested. And then the ones that were tested too late in life. So these are things that I think we're going to have to change, but we had to prove that there's bleeding symptoms in childhood. Otherwise, the genetic community and MASAC and everybody else are not going to change their minds on this. One of the things that comes up is that, well, if you test a child for a carrier state, she may decide to not have children, and you're altering her life, and she's not able to make that decision. Personally, bluntly, I think that's a crock. If you look at here, and I think if you look at the data, most women would not have changed their mind about having children. There are some women, and again, I think that in a different age, in the early 80s, I think that's a different story when women were seeing males dying of HIV and suffering from hepatitis compared to these days when that is not a problem in childhood anymore. And this is something that we're going to have to fix. 79% of women did not have their level checked during pregnancy. I think that's just a ticking time bomb. We were waiting for someone to have a horrible bleed, and and on my clock, I don't want that to happen. So this is the final set of data. That was my own personal Vanderbilt data. This is the CDC data. The CDC does not want this disseminated. This is preliminary data, just so everyone is aware. This may change completely, and we may not publish all this data, but just so you're aware that we can't use this to make policy decisions yet. So we wanted to see what about joint range of motion. And I actually went to the website and found that there were a lot of women that were, when you looked at the breakdown, there were a lot of quote-unquote female hemophiliacs. And so I asked the CDC, who are these women, and why hadn't anybody looked at this? And so we went ahead and got that data. It took about a year to get it. But we wanted to look at factor 8 and factor 9 deficient women. For all purposes, they're carriers, but I don't think we didn't have enough data to say for sure, but why else would they be recruited? But we all know, winking to everybody, that they're hemophilia carriers. We had to have a control group. Thankfully, the CDC they wanted to see what a woman's joints look like at age 9, age 20, age 30, and so that's really nice to have. And so we use that data set, which is public available, and anybody on this webinar could go to the website and get. And so this is the breakdown, and again, this is preliminary. So most of the people that were recruited, but you can see here, I was just shocked how many women were enrolled in this study. We're talking about, almost 500 women enrolled in this study. So that was actually pretty exciting to me that there were that many people in the data. And this was after removing people for bad information. So you can see it's predominantly Caucasian, about 70%. When you broke it down, you can see here 368 are factor 8 deficient females or carriers, and 158 are factor 9. That sort of fits with the general breakdown. These are mostly younger women in their 20s, but you can see there were babies involved and there were women in their 70s. And so this is the breakdown. We use the same definitions that you would use for a male. So if your factor level was 25%, you're a mild hemophiliac. If it was 4%, you're a moderate hemophiliac, and less than 1%, you're a severe hemophiliac. And so this is the breakdown. Not surprisingly, most of the women met the criteria for factor 8, mild factor 8 deficiency, followed by normal. I think that's probably because some women that maybe when they got enrolled, their factor level was higher that day for whatever reason. Severe, there were actually a large number of severe patients. I was actually shocked how many women were enrolled. And it was similar on the factor 9 deficient patients, and so it was very similar that most of the women were mild, as expected, because most women are going to fall in that 40 to 60% area. And so this table is very busy, but I wanted to have the joint numbers, and I'll focus on a couple of areas. So these are 20 to 44-year-old women with factor VIII deficiency or hemophilia carriers. This is the normal study, so these are normal women. And as you go down, these are the women that had factor VIII levels above 40% at the time of enrollment. These are the ones that had 91 women had met criteria for mild deficiency, 8 women met criteria for moderate, and 14 women met criteria for severe. And again, these are 20 to 44-year-old women. But as you can look across, the joint range of motion seems to have a dose response and go down over time. And that's expected. As your factor level drops, your range of motion drops. And so you can see a nice little dose response with regards to that. And so this was sort of enough data that we went ahead and moved along with it. And you can see the sort of the same response with the factor IX women. It's not as big because unfortunately the numbers are smaller. But you can see there seems to be a trend for mild hemophiliacs that the range of motion is less. And it's probably going to be worse in women because they're not being recognized by most providers. So we went ahead and did a little bit better analysis, and we're going to hopefully present this data at NHF as, if we're lucky, as an oral presentation. But we took all their joints, added them left to right, added them together, included hyperextension, and we subtracted it from the normal. And so these negative numbers indicate that these women have reduced range of motion. So this is another way of looking at it, and these are again in women that have factor VIII deficiency. And as you can see, it seems to have that same dose effect. So the lower the factor level is, the more reduction of range of motion, to the point that a female within age 2 to 8 has over 200 degrees reduced range of motion by age 8 on average, at least in these 10 people. And that's probably under recognition that they have this disorder, because most people aren't going to think that a female is going to have severe hemophilia. That is going to take quite an astute physician to pick that up. But you can see, we were thinking going into this that it was going to be 1-2%. I was not expecting such large numbers. The numbers are a little bit smaller over here on the factor IX side, so it's not as nice of a dose response, but every number is negative on here. And so that means that you're seeing reduced range of motion. We don't know if that doesn't always mean that it's functional, but once you start to get into 100 degrees loss of range of motion, you're going to have some functional defects. And again, this is very sort of pie in the sky looking at trends, and we're going to take this data to do additional studies prospectively, because this again is a retrospective study. And this is the table that we submitted to NHF. So this is not for dissemination because we haven't seen whether it's been accepted. But you can see here the normal women, again, we analyze in a slightly different way. But again, the range of motion seems to go down with the lower levels. And we did it this way so we can do statistical analysis. And a p-value, if you're not aware of, anything less than 0.05 is considered statistically significant. So everywhere, every cell where there's more than one patient involved, it was significant. And so, so we sort of were able to convince the last call that we just had, a lot of women, a lot of people on that phone call that were very skeptical were a lot more convinced. And so we have more data coming out of this. A lot of this won't be published probably for at least 5 or 6 months. But it's very encouraging, and I'm sure it's going to be rigorously reviewed. But I think it's going to be really important, and hopefully we'll be able to get this data out by the end of the year in manuscript form. So I think that will change the trajectory of how we take care of women that are hemophilia carriers. And so, following that roadmap, we can see here we've started with a prospective study, and right now I'm trying to figure out why in the world do these women have bleeding symptoms, because it's not enough just to know, we need to know why. And so we're doing some particular testing. The study is ongoing at Vanderbilt. We're getting close to being done, and then eventually we hope to get a larger grant so I can do multiple institutions, and I would love, HFA and various other organizations to be involved. And so hopefully next year we can start talking about targeted intervention, and then hopefully I'll have an idea of the mechanism. And so there are a lot of people involved in this. So I have a great number of people that are collaborating, HFA being one of them. Ruth Mulvaney was very helpful in the beginning. When we were talking about range of motion, I need to make sure that everybody believes it to be true. Dr. Goldenberg, who recently moved from Colorado, was very critical for this. The CDC was very important. This is the reason that we have government-funded research. If we didn't have this, we wouldn't have any of the data on hemophiliacs, period. And then we had a lot of people working, a great college student, fellow, we had lab people, a physical therapist that's working for free with us, and we had some other medical students from a local medical college. And so this picture is of probably some of the Russian women that were hemophilia carriers. Unfortunately, this was right prior to the revolution. But these women were very significantly altered and very disturbed by watching the hemophilia in their males, but also suffered symptoms that were going unrecognized. So I thank you very much for joining us, and I hope I left enough time for questions. And because this is very helpful to me, because when a woman tells me something that I didn't know about, oftentimes I go back and we'll go take a closer look at it. So it's very great for me. So thank you very much, and thanks to the Blood Sisterhood. Hope you guys don't mind having a male involved in the sisterhood. So
this is Lou again. I just want to remind everybody, when we unmute the phones, if you're not speaking at that moment or asking a question, to keep your phone, remute it yourself so that we don't have all the background noise. As you can hear, we're already getting some. So unless you're getting ready to talk, mute your phone, whether you've got a mute button or *6. We also encourage people to go on HFA's website at any point in time and see what we're doing when we're hosting new webinars. And I personally really want to thank Dr. Sidonio for this research and study that he's doing. And I think we need to encourage all this new next generation of hematologists to do these kind of things for us. So thank you. If anybody's got any questions, also, Dr. Sidonio, if you want to answer Katie's question, a 32-year-old who wants to know how many other women in the U.S. have hemophilia A.
So and one of the issues that we're having is, I'm working with Dr. Kulkarni of coming up with a proper term that would, for hemophilia carriers that are lionized or have less than 50% factor, what do we call those? Because I think symptomatic carriers is not a strong enough term. And so when you're talking about true hemophilia, meaning from Turner syndrome or other chromosomal abnormalities, I think you're only talking about 4 or 5, you're only talking probably about 100 women with true hemophilia, meaning they've inherited both mutations or they have lack of a mutation like in Turner syndrome. When you're talking about hemophilia carriers, it's just as prevalent as hemophilia in males. It makes sense. It's probably even more common, but we don't have good numbers on it, unfortunately, because the focus for so many years, and rightfully so, has been on the care of males. But I think we can take a step back and say, yes. So unfortunately, I don't have a solid number for that, but I think it's very similar to how many males have hemophilia in the United States, because we're just not seeing those women in our clinic, and I personally would like to start seeing a lot of these women in our clinic.
I have a question.
Go ahead.
I am a 64-year-old factor VIII symptomatic carrier.
Okay.
I have a severe factor VIII son.
Okay.
Two of the questions that have come, I am sitting on ice packs as we speak, but I came under some of the care of Dr. Kunkel, and she said as a woman ages, her factor level goes up. That's one of my questions. Is that true?
That's a little bit controversial. It definitely seems to go up with age. So it's when you look at the old data, and these are very old studies. I mean, not really that old, but when you're talking about bleeding disorders and you're talking about technology, they're old. So when you look in the 80s, when they looked at the extremes, meaning children, young children, and older women, that seemed to be higher at those ages and lower in the middle, sort of in the middle ages and in teenage years. So it does seem to elevate somewhat with age. I don't know if that may be protective, but one of the things that we've noticed is that even when women have 50% level, I can tell you, I didn't put this on the study, but we only had one woman that had less than 45% on our study. So these aren't a bunch of women with 10% factor VIII level that should bleed. These are women with 40, 50%, 60% levels that seem to bleed more than you would expect. So I think there's a functional defect in the mutation, and I think when you're carrying around a bunch of factor that's dysfunctional, when we look at factor VIII activity, we're not actually measuring activity. And so I think there's probably a better test, and that's why it's been a little bit difficult to correlate bleeding with factor VIII levels in women. And so I think we're hoping that we can work on something to come up with a better level. But to answer your question, I think the data does seem to support the level going up with age.
Well, that brings in my other question. My factor level has ranged from as low as 18% to recently 40%.
Yes.
And I understand that hormones and drugs and other incidents can make that factor level rise and fall.
Yes.
I'm still taking estrogen because I had a hysterectomy, and I'm taking estrogen to hopefully keep my factor level a little spiked. Is that true that that can work?
So it definitely has been shown higher doses of estrogen seem to make that. That's still a little bit controversial, but it does seem to be true because for a while when I would see a girl with heavy periods and she was started on higher dose estrogen, often we couldn't make a diagnosis of von Willebrand disease because it would mask the mild von Willebrand disease and make the levels higher. It can make von Willebrand factor higher, and it does thin the lining, which is not an issue with you because of the hysterectomy, but it does seem to thin the lining in general. So I think women that are carriers that often, before they get hysterectomies, get put on birth control, they feel better, then they feel like maybe it was a hormonal problem, when actually the hormones are masking it, which is a good thing. But factor VIII is very fickle. If you don't get factor VIII checked at a hemophilia treatment center or somebody with an on-site lab, it can be very low because it's very sensitive to heat when it travels. And somebody could have a cold and their level will double and triple. If you run for 30 minutes, your level will raise. If you're scared, if you're a child and someone's jabbing you with a needle for the 10th time, that factor VIII level will rise as well. And so, it's more troublesome, and that's why the range I think is large with women with hemophilia A carriers. Factor IX doesn't change with stress or infection or inflammation.
Oh, well, since I've been as low as 18 and now I'm at 40, does that really make any difference?
Well, personally, it's for me, if I had a woman that had 18 to 40%, I would treat her like a mild hemophiliac. I wouldn't even care that she's a female. I think that's where we have to break that down, that, this idea that you're symptomatic carrier, your levels are 18 to 40%, you have mild hemophilia. If that's where you live, then you should be treated the same as a mild hemophiliac. Obviously, we're not giving males, medicines to help their periods, but I think that's where the problem is. But I think if we start to sort of make people focus on the level and not focus on the gender, then I think people would sort of back away from that female carrier, sort of stigma and say, well, she has levels that are diagnostic of mild hemophilia. I'm going to treat her like a mild hemophiliac.
Well, my most important question is, I know how my son bleeds because he is severe.
Yes.
I, as a female, have never known for sure when I'm bleeding internally in my joints or not.
Yes.
Because if it's muscular, it doesn't show up, but it hurts very much, as well as knees. But it doesn't show up on X-rays or MRIs.
Well, the issue is when you have to do MRI, so it takes a fair amount of blood to show up. So X-rays, you're not going to pick it up unless you just have horrendous joints. And you're not going to see damage unless, you'll see a 50-year-old man that hasn't been doing prophylaxis. That's when you're going to see damage on X-rays, and you can see that visually. MRIs can pick it up, but often MRIs can't pick up. You have to do the specific type of MRI that focuses on the joint and on whether there's deposition of old blood. And so we did a very special MRI, and you can't just order a regular MRI. And so I think what's happening is for example, a male with severe hemophilia, when he gets a joint bleed, anybody, a blind person can see it. It's pretty obvious. And so the problem is when your levels are lower, it may not be as obvious. And so we were, some women that said they had issues with a joint, and we demonstrated that it was reduced. And one woman said she swears she doesn't remember having a joint bleed there, but when we did an MRI on her ankle, a special MRI, she had old blood there. And so there's not a lot of reasons to have old blood there, and it's something that we're exploring, obviously. I think once we do studies and verify this with larger populations, then we'll know. But if we don't have carriers being followed in the clinic, then we have absolutely no idea. It's sort of out of sight, out of mind, so you don't think it's a problem because unless a woman is going to, call a physician about it and bother them about it, quote unquote, they're not going to be seen in the clinic. So at least at most centers. So I think it's more of an out of sight, out of mind that people just don't see it, so they assume it doesn't exist.
I know many of us just get labeled as having fibromyalgia.
Well, that was one thing I did notice on our study, that there did seem to be a lot of chronic pain syndromes associated with it. And that is a lot more common than hemophilia carrier state. But it made me wonder, are women being, because it's a sort of a diagnosis, sort of a grab bag where when we can't figure things out, sometimes that's what it gets labeled as. But it does make me wonder when I did see a higher frequency of this, and I haven't been able to analyze it, that there does seem to be a higher frequency of women reporting the pain syndromes. And I don't know if it's related to this, but it's something that we wanted to look at. It's one of those things you don't know until you do a study, and so we'll hopefully explore that, and so it's helpful to know about that.
And what's going to happen with us as we age and have heart and cardiac issues when people don't believe that we really have a bleeding disorder to begin with?
Well, that's always challenging when you get older, and then the idea about starting aspirin and Plavix and these other platelet disorders may happen. Factor VIII levels that are mildly low are probably not protective of heart disease, so I don't think it's going to protect anybody. But one of the things that I didn't like are the large number of women getting hysterectomies in their 20s and 30s. I think that's somewhere where we can start, unless a real woman really wants a hysterectomy, which I don't think most 40-year-old women do. I think we should be identifying that earlier and providing other options. And it's something I didn't know about until I asked the mother when I said, "Well, are you planning on having more children?" And a lot of women said, "No, I had a hysterectomy because my periods were awful." And so, it's just one of those things that, it can be medically managed, stimate, at least for factor VIII deficiency, women. Intranasal DDAVP and tranexamic acid has been shown in studies to reduce menstrual bleeding by 40 to 50%. That with birth control could probably fix most women. And so, but it takes a lot of coordination, I can tell you. I have on my desk right now a letter, which I think is a perfect example of the problem from an OBGYN, a private practice one, which I have to give them credit. They emailed me about a woman that's a carrier.
Let me interrupt you, Stephen. There's a lot of other people that have some questions and stuff,
go ahead.
and I know we've reached our time, so I make sure that people, get a chance, other people get a chance to ask a question.
Yeah, go ahead. Go ahead.
Dr. Sidonio?
Yes.
I am a 40-year-old. My factor level is 17.
Okay.
Factor 8. I have 2 severe boys. And then I have 2 daughters who are, one's 5 and one's 8 weeks old.
Yes.
And their factor levels are 49 and 53. And so our treatment center has basically said they don't consider them to be hemophiliacs or require any, treatment plans or anything. My 5-year-old has actually had a bleed already in her hand. The baby hasn't had any bleeds yet, but I was just kind of surprised. My factor level is 17, so I actually have a target joint. I've had to have synovectomy on my ankle. I've almost bled to death following childbirth. That whole, I have that whole thing going on. But my primary concern is that as a teenager, my quality of life was actually quite poor.
Yeah.
So I get criticized by a lot of people because I feel strongly that girls should be, that if their periods are not normal, that we should be aggressive in finding treatments for them.
No, I mean, I think that's, that's what our prelim data shows, that most when you ask women when they had a first bleeding event, most of them had it in their early teen years. It was average age 12. And so that would indicate that these women should be monitored. And, we've been discussing with all our, when the girl starts having her period, you need to let us know. And, if they're heavy, we need to be involved. Because, when you're talking about an 8-week-old, as you remember from the slide, factor VIII levels don't hit the adult range until 4 to 6 months.
Yeah.
So it would make sense to TAVI test sometime again in the future, and particularly if there's any surgeries like tonsillectomies or anything like that need to be done, because it may drop a little bit. Maybe it's 40% or something like that, or it may rise, but it should be verified again.
Okay.
And so I think women that hover around 40 to 50%, I don't think they bleed as much as a hemophiliac, but I think they're at risk for slightly increased bleeding, and I think it probably does have to do with the mutation that you carry, and factor VIII activity I think is just not as predictive of bleeding as we think it is.
And wish it were.
I think personally, if the person has bleeding symptoms, then they should be followed.
And the only thing I have to say that the form that you have about the menstrual bleeding,
yes,
I love that idea. I know paper doesn't work as well. Maybe electronic would be better.
Yeah,
but
like an iPhone app or something.
Exactly, an app would be awesome. But for me, I had 14-day periods. So maybe 10 days isn't actually long enough.
Well, but once you hit that number, it's already so high. If your period is going that long, then your number is going to be so high. It's mainly just to pick up whether you have it. So if you have a score of, most people use 180 or higher, then you have heavy periods. That's all we're trying to verify.
Okay, good.
If your period is heavy. But I agree, 8 days, most of the time I have to say, all right, we have to stop at 8 days, even though our periods were 3 weeks long. So.
Yeah, because that's a quality, and that's purely a quality of life issue.
Yeah, it's a self-esteem and quality of life. I agree. I think we can minimize it. And to be honest, a lot of women I work with minimize it more than I was actually shocked by how many women minimize it. They assume that you're not anemic and it's not a big deal.
Yeah.
But I think it is. So.
I agree. Thank you.
As a man, I agree. So.
You're awesome.
Dr. Sidonio, this is Lou. I've got several questions. I know. Are you willing for me to read the ones that people have typed in?
Sure.
Okay. Well, Sandra said it's a great presentation, but she wants to know whether there's any effort to collaborate with national OBGYN groups to educate providers.
So there is the Foundation for Women with Bleeding Disorders. I think that's a really good start, and it's run by incredible people, Dr. Conkle, Andy James, and Dr. Kulkarni. They're quite powerful and advocate for women with bleeding disorders. I think we're actually applying for one of the NHF grants to try to produce materials for NHF. That's one of our goals. Because I think we have all these nice guidelines, but when you have 20-page guidelines, no one's going to look at them. And so I think we need to have some sort of distill them into some smaller handouts. And, it all starts locally. It's just like politics. And so I think we want to educate our local providers, and I think that is a good start. So if every provider does that, then I don't think it'll be a problem. It is getting better. If you look at old surveys that Dr. Dietrichs did, it was under-recognized, but it does seem to be improving. So there is a national push for this, though. So it is happening.
And so wants to know, how often is it a problem when you get IVD to AVP to have side effects such as nausea and vomiting, wheezing?
So I think it is pretty common. That's one of the most common symptoms. Every woman's going to get flushing with it, that's for sure. We don't have issues with the fluid restrictions because, we don't have any issues with the sodium being low or seizures because we're very strict here about that. I usually recommend it for girls that are using it for their periods to give it at night before they go to bed. Because a lot of girls don't like the way it makes them feel, and I didn't even know this until somebody told me that they didn't like to go to school with their face as rosy red, and so that's not something I even thought about. And so we talked about it and we said, well, why don't you give it at night on the first and third day of your periods, and that does seem to help a lot and reduce the headaches, the nausea, that's associated with it because you're going to bed anyway. And so, and then you don't have to worry about fluid restriction because you're going to sleep. So we haven't had as many issues, but we have had some girls that it's been intolerable, but that's a very small amount. I think how much it helps is sort of greatly exceeds how much the symptoms are.
Someone asked, is EDS and BWD commonly diagnosed together?
Ehlers-Danlos syndrome, I feel like it's common. I do have 4 patients now with it. I didn't put a lot of this discussion in this, but one of the sort of under-recognized bleeding disorders is Ehlers-Danlos. And I didn't know that it was that common. Again, it's one of those out of sight, out of mind, and so it's easy for people to say, well, I've never seen it before. Well, I think it's pretty common. I can tell you I referred in the last 12 months, I think I referred 8 patients with Ehlers-Danlos that were confirmed genetically. And they were coming to see me for bleeding symptoms. And so I always wondered if I was missing these, and I remember talking to Dr. O'Brien and a couple other providers about the Ehlers-Danlos, and there's a simple exam that you can do this to look for hypermobility. I don't think it's not something that's co-expressed or it occurs definitely with von Willebrand disease, but if you take 2 disorders that are common, you're going to see them together. And so, I have patients with sickle cell trait and von Willebrand disease that have bleeding symptoms, and so unfortunately, when you take common traits, you can mix them together and get some unique combinations. But we have plenty of children with that, and Ehlers-Danlos has completely normal labs, so that's why it's a little tough. So you really have to do a good exam.
Somebody said that they had received, after they've got BWD, and they received Hum-8P for 10 days following the C-section. And then a week after was admitted for postpartum hemorrhage. Are there studies or literature or report on postpartum care in women with bleeding disorders?
So,
but she's pregnant right now, and she wants to know how long she should be treated for.
Well, based on the, what's been reported, so women that have C-sections would be up to 7 days. So whoever was treating you was doing more than what was recommended, at least. The issue is that having a post-pregnancy contraception plan is important, because a lot of times that contraception will also help with menstrual bleeding suppression. For example, IUD, those kind of things. And so the answer typically is 7 days for C-section and 3 to 5 days for vaginal delivery, where you need to keep the level above. But there are probably women that are going to bleed outside of that, and that's why close follow-up is important.
But if she previously bled farther out, should she be treated? She should think about considering treatment for 3 to 6 weeks.
Well, that's where I think having a good plan, postpartum plan, yes, I agree. There's the next pregnancy, there should be a postpartum plan of how are we going to address the increased risk of bleeding in the first month after pregnancy. And that may mean, a PICC line with getting factor on a regular basis, or that may need, high dose, estrogen and birth control to help augment the factor replacement, or even, the tranexamic acid use as well. So I think that should be a plan to have in the future, because if you have bleeding the first time around, you should try to prevent it the second time around. I agree. So.
I know one of the things you had mentioned about the vitamin K to still do it, because I know some doctors used to say, do the oral vitamin K. Isn't that less effective?
Well, that's the problem is, and so, there was a time when people thought that vitamin K, according to a British study, had an increased risk of cancer in childhood. And so whenever you come up with a study like that, you're going to pretty much reduce the amount of vitamin K injections. And so they changed the formulation, similar to the way they did with vaccines and the concern for autism that was sort of debunked. But once the data is out there, it's hard to pull it back. And so places like England and Japan stopped doing it, and GI bleeding and bleeding in the head went up significantly. The issue is you have to continue to take it and continue to take it at home for prolonged periods of time, so for weeks. And so, that's one of those things that people are going to it's going to drop off when you have a newborn, giving oral vitamin K. So it doesn't stick around as long. The IV form, the injection form, and IM form sticks around for 4 to 6 months, and so it pretty much almost completely eliminates any chance of bleeding. So unless you have a liver disorder. So I have seen liver disorders sort of wipe that out. But I personally have not seen that. That's what we recommend, and we always tell the mothers to report to us if we've seen it. And I personally have not seen it, a problem with injections.
Does anybody else have any other questions? Well, I want to thank everybody for getting on tonight, and especially Dr. Sidonio for his presentation. That make sure that you check out HFA's website for future events. And I think a lot of you were giving the slides so that you could take notes. Sent in your if you gave us an email address, sent you an email so that you have the information for further reference.
Well, thank you, everybody.
Thank you, everybody, too.